Hi, good morning, everyone. Thanks for coming on to Zoom for our department grand rounds. And we're going to get started now. Everyone is muted, and we'll have everyone stay that way. And then as we get to the end, I'll ask you to put any questions in the chat, and then we can have for Dr. Glassberg to have a discussion with us. And so welcome again, really appreciate it. Thank Dr. Glassberg for taking on the remote Zoom grand rounds for us. This is our first remote one. And so with that, I'll turn it over to Dr. Warmer, who will give us our introduction.
Good morning. It's exciting to be able to introduce our first fully virtual Department of Medicine grand rounds. For our speaker today, we have the pleasure of hearing from Dr. Jeffrey Glassberg. Dr. Glassberg is an associate professor in both emergency medicine and hematology oncology at Mount Sinai Hospital. He earned his MD as well as a master's degree in clinical research from Washington University in St. Louis, and then completed his residency in emergency medicine at NYU, followed by a research fellowship at Mount Sinai, after which he joined the faculty. In addition to serving as an attending physician in the emergency department and as the primary physician for many Mount Sinai patients with sickle cell disease, Dr. Glassberg also serves as director of Mount Sinai's comprehensive sickle cell program and director of sickle cell research. As a researcher, his interests include pulmonary complications of sickle cell disease, biomarkers for vaso-occlusive crisis, and novel agents for vaso-occlusive crisis prevention, as well as evidence-based approaches to treatment of patients with sickle cell disease and sickle cell pain crises. Please welcome Dr. Jeffrey Glassberg.
Thank you. Let me try to share my screen here. Okay. Good. Okay, thank you very much for the introduction. Can everybody hear okay? Thumbs up? Good, okay. Yes, I'm using my son's professional quality karaoke microphone for this now. So the topic of today's lecture I chose is sickle cell disease past, present, and future. And as James indicated, I am director of the Sickle Cell Clinic. I take care of 350 adults with sickle cell disease, and it's a pleasure to talk to you today. Most of my funding is through the NIH, but I do also have a grant from the Doris Duke Foundation and have done some consulting with Global Blood Therapeutics. And I'm now running a COVID drug trial from Eli Lilly, new COVID drug that is unrelated to sickle cell disease. Some of the funding for the research I'll talk to you about is also through National Eye Institute, as well as Heart, Lung, and Blood. And these foundations have funded our ocular research, which you will hear about. So just a little bit of background, sickle cell disease. It is most common in sub-Saharan Africa, but we also have quite a bit of it in the United States. There are approximately 100,000 individuals in the United States with sickle cell disease, which is significant. We call it the most common rare disease in the developed world. However, if you compare that to a country like Ghana, they have 100,000 births per year with sickle cell disease. So the problem is much more substantial in certain parts of the country. And the pathophysiology, we'll go through quickly. Sickle cell disease, the most severe form, is caused by a point mutation at codon 6 of beta globin, where you replace glutamic acid for valine. And that causes you to make a different form of hemoglobin called hemoglobin S. And hemoglobin S has the unusual property that when it releases oxygen, drops it off at tissue beds, the hemoglobin polymers stick to each other and form these long rods that then occupy the inside of the cell, change the shape of the cell, damage the cell membrane, and give it that characteristic sickled shape. That event of sickling and damage to the membrane causes the cycle of vaso-occlusion, where damage to the red cell membrane causes inflammation, cell activation, then cell adhesion, which then causes vaso-occlusion and ultimately causes tissue and organ damage. It also results in a hemolytic anemia, where the damage to the red cell causes the red cell to break apart, resulting in lower hemoglobin levels and hemolytic anemia. Clinical manifestations of sickle cell disease occur in every single organ system because the blood flows to every organ. Our most common manifestation, which we know very well, is pain crisis, painful vaso-occlusion, as it is sometimes called. But we see manifestations in every organ system, from the brain to the skin and the eye. So if I were to break sickle cell disease up into 3 eras, the past I would describe as the era of not enough therapies. Hydroxyurea was the only drug that we had for quite some time. It was discovered in the 1970s, FDA approved in 1994, and it works by several mechanisms. It raises fetal hemoglobin production, reduces leukocyte activity and production. It donates nitric oxide. And ultimately, after 40 years of using this medication, we have come to understand through research that hydroxyurea improves pain, organ function, and prolongs life. And you can see down here the therapeutic timeline I've created, a visual for what sickle cell disease therapies included, and it's quite sparse. So the way we conducted research to a large degree in this era of not having therapies was to try repurposing existing medicine based on our knowledge of sickle cell pathophysiology. And throughout this era, we really did have an excellent understanding of the pathophysiology of sickle cell disease. And so my research focused on one potential line of attack, which is that sickling is reversible. Red cells will drop off oxygen, they will sickle, and then they will return to the lung where they get unsickled. Some are permanently sickled red cells. Those are the older red cells, but younger red cells can be reversibly turned back to their discoid shape. And that occurs in the lung, where the lung oxygenates the blood. Based on this idea, we first started to realize that people with asthma seem to have much worse sickle cell disease. There was a 1983 case report of a young girl who had crises every time that she had an asthma attack. And some of the research that we did, we found that patients with asthma and sickle cell disease are more likely to have crises after their pain crises after their asthma attacks, more likely to have acute chest syndrome, and more likely to die young. And the mechanism of this was thought to be relatively straightforward. You have VQ mismatch and all these pulmonary abnormalities in asthma, which create regional hypoxia, which leads to more sickling. And so it makes sense that patients with asthma would have more severe manifestations of sickle cell disease. Certainly that brought up the question of whether or not we should be using steroids to treat asthma and sickle cell disease more aggressively. And if you give an individual with sickle cell disease steroids, it very often will take away their pain. Giving steroids during an inpatient admission reduces the time to discharge, so pain crises resolve quicker. But unfortunately, steroids quite reliably cause what we call a rebound crisis. So the minute you stop the steroids, patients will have a more severe pain crisis. And we've seen this many times, especially I have patients who had never had a pain crisis in their lives. They had a mild phenotype of sickle cell disease, and they were put on steroids for a reason unrelated to sickle cell. And immediately after the steroids are stopped, they have the first crisis of their life, sometimes severe, sometimes even acute chest syndrome. So oral steroids, systemic steroids are not a long-term solution for sickle cell disease, and they're not an ideal treatment for asthma and sickle cell as well, which is why when you do have an asthma attack, we encourage shorter courses of steroids. Even sometimes a single day of prednisone could be tried. With all this research in asthma and sickle cell disease, we noticed an anomaly. We would expect inner city African Americans to have about 10 to 25% prevalence of asthma. And we observed much higher rates of asthma in our sickle cell population. When we did methacholine challenges, which is something that you really shouldn't do, we learned on people with sickle cell disease, you find airway hyperresponsiveness in sometimes 8% sickle cell disease, which is dramatically higher than the general population. Then we looked at the Berkeley mouse with sickle cell disease and found that even without asthma, sickle mice have in their lungs. And when we section those lungs, we see perivascular inflammation, lymphocytic infiltration. Then when we looked at human beings and tracked their symptoms, we found that many people with sickle cell who don't quite meet criteria for a diagnosis of asthma exhibit wheezing episodically. And there is actually not complete overlap between wheezing and asthma. That if you follow patients with sickle cell for long enough, close to 70% of them will report periods of cough or wheeze. And so that led us to the question of, and we found that in those individuals who do report cough or wheeze indeed have more pain and more death as well, even if they don't meet criteria for asthma. So that led us to this question, even in people who don't have asthma, is inhaled steroids a good option for sickle cell disease? We know that systemic steroids are not an ideal choice, but what about inhaled steroids? And the idea being that if you improve oxygenation, reduce VQ mismatch, you may reduce sickling and reduce manifestations of sickle cell disease. So that led us to the IMPROVE trial, which was a double-blind, placebo-controlled, randomized trial of inhaled mometasone dry powder inhaler, once daily dosing. We chose that because mometasone is a potent inhibitor of SVCAM, which is found to be elevated in sickle cell disease and tracks very closely with morbidity and mortality. And so after this trial, which was small, about 45 patients participated, we found a significant but small reduction in pain scores over time. SVCAM was significantly reduced by about 14%. We saw a trend in reduced admissions. And when we looked at other biomarkers, all the trends were in the right direction, looking promising in this small study. TNF alpha seemed to go down, hemoglobin seemed to go up. Reticulocytes and other markers of hemolysis seemed to be reduced in people who took inhaled steroids. So that led us to a larger trial, which is the current R01 that we're doing, which is a phase 2 trial of inhaled mometasone for people with sickle cell disease that do not have asthma. Patients this time will take the drug for an entire year, which really helps us understand, is this just a good adjuvant therapy for people with sickle cell disease? We've enrolled 39 out of 80 people, and we're doing induced sputum, which we have put on hold, obviously, because we don't want to aerosolize things, but we're doing induced sputum, and we're identifying all the cell populations and immune cell populations in the lungs. And we've seen sort of trend towards the importance of CD14 monocytes in the lungs seem to be a very important player in patients who do not have asthma, but have sickle cell disease and respiratory symptoms. But this is really an era that I think has come to an end in sickle cell disease, of just sort of pulling medicine off the shelf and saying, well, maybe this would work for sickle cell disease. Maybe this would help a little bit. Now we have a new problem. We have too many therapies. Here are just some of the therapeutic targets that have been tried for novel sickle cell therapies. Hydroxycarbamide is hydroxyurea, and we know how that one works, but there are anti-adhesion agents, anti-sickling agents, antioxidants, anti-inflammatory, and anticoagulants. And so at this very moment, we have 4 FDA-approved drugs, and by my count, 39 more in development. And then we have gene therapy, which is very soon going to be available to any patient with sickle cell disease. But the problem is that labs that we follow and symptoms vary heavily for reasons sometimes other than sickle cell disease, and figuring out whether whether a drug is working well for somebody can take time. You have to follow a patient, follow their symptoms, follow their labs. So how do you select the right treatment regimen for a patient, and how do you decide whether or not it's working for that patient? We have crizanlizumab, which is a p-selectin inhibitor. We have voxelotor, which is an anti-sickling agent. We have L-glutamine, which is an antioxidant, a nitric oxide a donor, and hydroxyurea, which we've mentioned before. So like I said, titrating therapy in sickle cell disease is a challenge when now you have several medicines that are FDA approved. The drugs, the data supporting them in some cases is quite strong, but they have not been tested together. They have not been compared to each other. They've only been tested in sickle cell disease with hydroxyurea. So the other ways that we follow people are we just wait for bad things to happen, like complications, and transcranial Doppler is another imaging modality we use to track risk of having bad things happen. So that led us to this next project, which was using the eye as a window into what was happening in real time in sickle cell disease. And could that help us with this problem of evaluating whether a therapy is working? So this was a tremendous effort, collaboration with the New York Eye and Ear Infirmary and Richard Rosen's lab. And so here are the people that helped with this project. And this really has to do with two technologies. One is called OCT angiography, and the second is called adaptive optics. OCT angiography is something that you'll find in most academic retinal centers. It's widely available, commercially produced, but adaptive optics is very, very much an emerging technology where you really have to build the machine yourself. And that picture on the right that's what they look like, with all these mirrors and machines. So what we see with OCT angiography are these pictures below. You get an image of the retina and the blood vessels and whether or not they are perfused. So in terms of this technology, what we wanted to do was come up with a simple quantitative measure of what is going on in a person with sickle cell disease. Up to this point, people had done a lot of research with OCT angiography, sickle cell, but it really was just focused on this is abnormal in patients with sickle cell disease. It didn't really move towards a way of using that imaging and quantifying what it meant for people with sickle cell. And so when we imaged patients, we saw that certain blood vessels in the retina were not always perfused. And so we developed a new measure of OCT angiography where we took two imaging sessions, 1 hour apart, and then compared what we saw. And then we used image processing to identify the areas of the vasculature that were intermittently perfused. And you can see in this 31-year-old, you have on the left, before treatment with hydroxyurea, lots of areas highlighting that were not consistently getting perfusion over the course of 2 imaging sessions an hour apart. Whereas on the right, you see much less of this highlighting. And we can quantify the percent of this image that is not reliably perfused. You can see on the left, it's 2% of the image. And on the right, it's 0.74% of the image. And so that became our simple quantitative measure of how much unreliable or intermittent perfusion we were seeing in these capillary and venular beds. But what is the mechanism for this intermittent perfusion? What is actually happening? And that is where adaptive optics come in. Adaptive optics is this technology where you have to build your own machine. What it allows you to do is magnify somebody's retina to the point where it's basically a microscope image. And the reason you need the whole setup is because just the subtle movements of the eye are so great when you're magnified at that scale that you need a mirror that will adapt to the subtle movements of the eye to hold your image steady so that you can see. And so we were using non-confocal adaptive optics to visualize individual blood vessels and even individual cells in the retina. And you can see that when you rotate the detector on your non-confocal adaptive optic magnification, you can see different features of the vessel wall. You can resolve different things flowing through the blood. So you can see direction of flow. At this image here where the yellow arrows, you can actually resolve which way the blood cells are flowing. Control. And you can resolve looking at. So you can see the flow direction on the left. And then if you look at the image on the right, which is a still, you can see leukocytes, which based on the scale here, we can see that this squished leukocyte the plasma space. With sickle cell disease. Image that we saw that was not reliably perfused. You can see over 1 minute this single vessel is flickering. We know that that means there's intermittent blood flow. So what was the mechanism here? We see on the left-hand side, when the blood vessel was not visible on OCTA, there was blood flow, and during periods of good imaging, good forward flow. Another image, an intermittently perfused capillary here from patient. This is a female with hemoglobin SS. And when we went to the adaptive optics, what we saw causing her perfusion was a red cell rouleau, which you see on the top. That through the capillary. You can resolve as you rotate resolve the individual red cells that are breaking off of that rouleau. This, we think, is the first image of a sickle cell getting stuck in a blood vessel. Paul Frenette, who used to be at Sinai for in the Berkeley mice, to our knowledge, this is the first image human being having vaso-occlusion with a sickled red cell. Bottom left of that sort of tubular shaped cell. Notably, in contrast to the vaso-occlusion in the mouse, white cell vaso-occlusion was a very rare event, so much more red cell vaso. So here's a completely non-perfused, looked with adaptive optics. What we saw was sludging, so red cell fragments and sludge causing stasis in that capillary. You can see also there's pathological translocation because of this sludge, those blue arrows. And then distension over here of another capillary. You can see plasma stasis in front of this red cell sludging. That's the yellow arrow. And so then we looked at what happens when you treat somebody with hydroxyurea to these images. So on adaptive optics, we saw resolution of flow through many capillary beds. Here's a sludged capillary on the left, the red arrows, and we saw after 2 months imaging that same capillary, that flow was restored. Resolution of vaso-occlusion at a capillary bifurcation. And you can see that there was a non-perfused capillary that we resolved perfusion in after treatment with hydroxyurea. These capillary flow voids, that's what I had just mentioned. Again, pre and post treatment. Resolution of another capillary flow void. So you can see on the left, this is just an empty, non-perfused capillary bed that after hydroxyurea, we restored perfusion. So this was an important point that treatment with hydroxyurea did improve vessel perfusion in a number of areas, but it did not resolve. We still saw abnormal blood flow. We still saw abnormalities in the blood flow through through the retina. And here you can see abnormal blood flow through a vessel after treatment with hydroxyurea. We still saw erythrocyte rouleaus, which is something that we do not see in healthy controls or diabetics. And so ultimately, these were the main mechanisms of vaso-occlusion that we identified were erythrocyte rouleaus, sickled red cells causing vaso-occlusion, red cell aggregates, and red cell sludging causing stasis, and finally plasma stasis. So the question that we wanted to ask next or what can we do with this information? And so the data is too preliminary to show at this lecture, but when we categorized individuals based on sickle phenotype and whether or not they had been successfully treated, this OCTA-based measure of the percent of your retina that has perfusion flux seems to track remarkably into very distinct categories of untreated severe sickle cell disease, maximally treated with hydroxyurea sickle cell, severe sickle cell, and then the milder phenotypes like SC and S beta thal plus have even less perfusion flux. Then you have patients with sickle cell trait, and then finally below that, healthy controls. And when we just imaged one individual who was cured with gene therapy, and he still has some abnormal features, but his perfusion flux is basically in the range with sickle cell trait, which is just as we would expect. So the potential utility of this, now that we have seen in our preliminary data that the perfusion flux measurement really does seem to track very closely with how successfully you've been treated. The next question is, can we evaluate a patient before and after treatment with a new drug? Can we evaluate a patient before and after adding or changing a drug and creating combinations of new drugs to see if can we get people with sickle cell disease down into this range where your perfusion flux measurement is going to be similar to someone with sickle cell trait or a patient who's been cured with gene therapy? And does that perfusion flux measurement actually track with real outcomes like pain crises and and laboratory markers of disease severity. And so that's where we're going next with this. And we hope that that will allow us to more rapidly titrate patients' therapy rather than just waiting for labs or permanent complications to occur. So the next era, which hopefully will make that research obsolete, is curing sickle cell disease. So in terms of what we would want out of a sickle cell cure, would be something that's non-toxic, something that's accessible to a wide variety of patients, and something that can be scaled to deliver a large amount of this cure. Today, we have cures for sickle cell disease, and I put that in quotation because there are limitations and drawbacks to these. So bone marrow transplant, we know, is a cure for sickle cell disease in the sense that if you get a bone marrow transplant, at the end of that, you will not have sickle cell disease. The problems are, first of all, a fully matched transplant requires a match, and less than 10% of our patients have fully matched donors. The conditioning and myeloablative regimens can be very toxic, although there is a large amount of research on less toxic and less aggressive myeloablation regimens. Any patient can have a haploidentical donor, but those have higher rates of graft versus host and more concerns about safety. Gene therapy is here today. We have two of my patients have gotten gene therapy. It solves many of the problems. You don't need a match because you are your own donor. There is no graft versus host disease after you've been cured, which is very promising. But there is still the myeloablation problem that you are likely to not be able to have children after getting gene therapy or a bone marrow transplant. And there is still substantial toxicity from the conditioning and myeloablation. So the way gene therapy works is you produce a virus with a therapeutic payload. You take out the target cells that you want to fix. In our case, that would be CD34 positive hematopoietic stem cells. Then you take those out of the patient, take them to the lab, and edit the cells with a gene therapy procedure. You have to expand cells, and this is one of the key steps that has really become one of the barriers that where a lot of this proprietary technology occurs is the editing and the efficacy of the editing and then the expansion, because you do need about 500 million cells that are properly edited to introduce back into the patient. Then once you have your 500 million cells, you myeloablate and condition the patient. Basically, you poison the patient to make enough room in the bone marrow niche for these edited cells, and you give them back to the patient. We are using mostly viral vectors for this purpose, which are delivering a new gene or and something to edit. The furthest along technology is the Bluebird Bio BB305 product, which involves you take out the stem cells. They do their editing via lentiglobin, which is a cousin of HIV, and the Bluebird Bio product delivers an entirely new gene for hemoglobin. It's a modified hemoglobin that has anti-sickling properties, which is very useful because they have created this modified hemoglobin in such a way that it can be separated from the other hemoglobins you'd find in the patient. So you know exactly how much Bluebird Bio hemoglobin the patient is making. But again, the cells have to be taken out. They have to be edited in the lab. The patient has to be given busulfan and myeloablation, and then reintroduce the product. And at 2 years of follow-up, or actually we're much further than 2 years of follow-up, patients are doing quite well. The other major strategy for gene therapy is using CRISPRs to edit BCL11A, which is a gene that is a fetal hemoglobin suppressor. So if you use a CRISPR in your virus to turn off or knock down BCL11A, then you'll start producing more fetal hemoglobin. So both of these strategies seem to be effective in the early studies. You can see this is a presentation of patients who've had the Bluebird Bio treatment, and you can see on the left all the pain crises they had before they were cured, and on the right that basically you've had eradication of symptoms. And I will tell you that my patient who had the therapy has a hemoglobin of 13.5. He runs 3 miles a day, and he has not had any symptoms at all related to sickle cell pains since he was cured. And he had a tremendous amount of sickle cell pain. He had frequent crises. So it's been just absolutely incredible to see what he went through. But he did get very sick during the conditioning. He was in the ICU at NIH for, I think, 5 weeks, and had several complications, which have fortunately resolved. So where we are now with gene therapy, it's very promising. Theoretically, any person with sickle cell disease could get this treatment because you don't need to find a donor. But the way it is right now, it is too toxic, and and it's not scalable because this you still need extremely specialized facilities to take the cells, to edit the cells, to expand the cells. It has to be done in a very rapid turnover time. Then those edited cells have to get right back to the patient wherever they are in the hospital and infused into the patient. So the timing and the resources, and then having a bone marrow transplant unit where a patient can undergo all this stuff is a major limitation that really puts this therapy in a place where it's not something that you could just make available to everybody, especially across the world. So the next step that we are working on is, can we do in vivo editing instead? Can we directly inject the vector to cure the sickle cell disease in the patient? Right now, with the technologies that are out there, this does not seem like a path we can take. The Bluebird Bio product is probably too big of a genetic payload to just inject the viral vector into the patient and reasonably expect that nothing bad would happen. And then BCL11A is a gene that's expressed in a variety of cells, all leukocytes, and off-target effects would be a major concern when you're editing that type of gene. And if it's done in the body, once it's in there, there's no taking it out or going back. So we'd have concerns about causing leukemias and other white cell cancers if we were just editing BCL11A in vivo. But we are working on some strategies to overcome these issues, but these are highly preliminary. So hopefully the next grand rounds I give in a few years, we can talk about how we solved all these problems. So those are the 3 eras of sickle cell disease. Past is repurposing existing drugs. Present, we need to use non-invasive technology to evaluate novel therapeutic combinations and guide treatment. And hopefully in the future, we'll just have a cure for sickle cell disease. Thanks to our clinical team, Gina Simon, Charlene Jacobs, Brittany McCrary is our new nurse practitioner, and our social worker, Joanna. And I would be happy to take questions.
Great. Thank you, Dr. Glassberg. Thank you. Appreciate that very much. And now I invite people, if you want to put questions in the chat, it'll probably be easy. Give it a minute, Jeff. If anyone is on a device that they not, is too small to type in and you want to unmute yourself and ask a question, that's fine too. No, we do have a question. Jeff, I assume you can see this.
I do see that, yes. Do carriers of sickle cell trait have higher rates of asthma? This hasn't been thoroughly studied the way that it has in people with sickle cell disease, because people with sickle cell disease are sick and they come to the sickle cell center, and they had just been sort of subjective to that higher level of scrutiny where we're evaluating patients and doing pulmonary function testing and identifying these abnormal pulmonary characteristics. So we do not know, but as far as the large data research that people are doing, we haven't seen higher rates of just sort of that ICD-9 diagnosis. Next question, what level of fetal hemoglobin is needed to achieve a cure via BCL11A? 20% is thought to be the magic number, that if you're above 20% fetal hemoglobin, we don't see symptoms. So that's one important threshold. Does 20% mean that you'll have a normal lifespan, that we will not see organ complications? Probably the number is higher, and higher is certainly better. And I'm extrapolating that from sickle cell trait, where we know that people have about 55% normal hemoglobin, and they still have higher rates of renal disease in their 50s and 60s and other complications. What would be the cost of combining drugs other than hydroxyurea? So the cost would be extraordinary. The price for crizanlizumab is about $90,000 a year. The price for voxelotor is $125,000 a year. So if you were to combine, have a patient on crizanlizumab and voxelotor, you're talking about a $200,000 a year price tag for a treatment that this individual could theoretically be on for the rest of their life. So these are just astronomical prices that probably are not sustainable.
Other questions? A couple very good questions there. There's one, Jeff.
Excellent question. How do you resolve red cells versus white cells? We do it by the size. That leukocytes are much larger. The red cells are going to be 5 to 10 microns, and the leukocytes could be 20 plus microns across. So that's how we resolve them.
Anyone else want to comment or have a question for Jeff? Great. Well, if not, I want to thank Jeff and thank his son for letting him use his mic, and we appreciate that. And so really appreciate you coming and talking to us. And everyone, Jeff is here at jeffrey.glassberg at Mount Sinai if you have questions to follow up with him. So if not, have a great day, everybody. And thanks for coming to Grand Rounds. Take it easy.
Thanks so much.
Thank you. Thanks, Deb. Really appreciate it.